And the speaker is Mukesh Kumar. He's a Senior Director of Advanced Process Technology at Zimmer Biomet, where he's responsible for teams in research, design, process, and operations. The groups there are actively involved also with additive manufacturing for clinical use. He has published, he has patents also in his name, and he has also written a book chapter on personalized implants in additive manufacturing in a recently published book on additive manufacturing. So he's well placed to discuss this topic with us. Mukesh, please.
Thank you for that introduction. Thanks for the organizers to inviting me to this presentation on engineering perspectives or evidence for engineering perspectives on 3D printed patient-specific implants. First of all, right off the gate, I have to confess, we do not have 3D printed patient-specific implants in the marketplace yet. So then what are we talking about? As I think through this, the more I think about this and the more we gradually develop our business around this, this whole talk is about evidence. And as we think about how we're going to bringing it in, I will be talking about what could be a measure of evidence. If in the session that we had, there was pretty heated arguments on, I was the hospital payer, and the manufacturers, my colleague from Depew, and we argued on why I should not pay, and they argued why I should pay. So, but this will help us think through what could be measures and evidences that we could put in place to try to get reimbursed. So with that background, at the end of the day, what is our orthopedic implant? It is designed to restore mobility, right? At the end of the day, we know that. But then, just like any other implant, it needs to survive in the body for years, right? Functional in a hostile environment. It needs to osseointegrate into the body and be functional enough to take body loads. Perform under fatigue conditions. So if you look through this, and if you understand this, if we try to build our evidence, right? This is true regardless of whether you're trying to talk about a generic or conventional implant or a patient-specific implant, right? So the thing becomes then why patient-specific? That's the question we are trying to answer. And by the way, I may not have the answers to these. In the industry now, we have come up with what we will call generic implants. Quite a few of these 3D printed generic implants are out there now. Acetabular cups are there, spinal implants are there. Most are for what I will consider they are functional in low fatigue environments, so they are not necessarily for like a hip stem where the trunnion is 3D printed. In fact, in the industry, this is a slide I took off from Dr. Steve Pollack at the FDA. He had presented this in America Makes. The FDA has been pretty gracious and reviewing these, and quite a few 3D printed implants are out in the marketplace now. So if you look at this, there are hip cups, spinal cages, knee trays, there are dental devices out there, patient mesh guides that we talked about. I didn't find actual cases on the web on these, but apparently there are quite a few patient-matched implants in the orthopedic world, but I do not know if they are 3D printed. And then there are, of course, emergency and custom devices. So the reason why I'm bringing this up is, at the end of the day, these implants serve a purpose. The question is, what is the advantage of patient-specific implants? And if we think that there's an advantage, how do we build an evidence around that? Okay, one of the implants, and I will quickly serve on this, is it's not limited to metals, of course, 3D printed implants. This is an example where Zimmer Biomet does it through our craniofacial department. And this is a cranium flap. Now here, an advantage is pretty obvious. In the old days, this was done with a metal implant. Especially on kids, a metal implant would get incorporated and would start putting pressure on the brain. So reimbursements on these kinds of implants are much easier. It is a obvious situation. So the case to build an evidence around this is not that severe. But here you can do that over here. Does that translate to a regular acetabular cup, which we have made patient-specific, but it could have been done by a generic implant? Probably no. So the FDA, again, a slide from Dr. Steve Pollack. FDA has given us some ideas on what we need to do to submit this information. So type of imaging, right? Is there a way, can we build up our argument that the imaging that we are getting and the image processing that we are doing will give us a better implant and a better outcome. So we had this discussion on our table, and we talked about the planning and the output of the planning. But before the planning, the imaging is also very important. Are your protocols, are my protocols that effective in giving us a better implant? If that is the case, then we can build a case around patient-specific implant. I'll jump through some of these, but the digital design, right? So a patient-specific implant has been made. We are making this, and there is a reason why we have designed it this way. If we look at this, is there an argument behind it that we can put forth that these patient-specific implants encompass this kind of biomechanical attributes or osteo-integration attributes that a payer would be more inclined to pay for? Right? So we are answering the questions that the FDA is also wanting to do, but can we use that to answer questions for the insurance companies? And of course, as we move around, there are certain things that we still have to decide. One of the reasons why Zimmer Biomet doesn't have a patient-specific implant through 3D printing are issues like finishing and cleaning. We are not 100% confident you can do this across the board, but once we get that, that would work. Okay, so patient-specific implants have been around for a long time. In fact, Andy has been doing this for a very long time. Zimmer Biomet has been doing it for a long time, right? But they have been all made by traditional methods, where you take a machining bar stock and you machine it to different dimensions and you do your coating on top of that. And as we go along, I'll give you a few examples of these. But as I give you a few examples, what you have to understand is not everything is known in the design of a patient-specific implant, because not every aspect of biomechanics is well described in literature, where every example of a disease is not, and then when you remove the bone around, is not well described in literature. So what kind of forces and stuff what this implant will be taking is not well described. But if we had a way to consider these and argue that there is a need for this implant and there is a need for this feature, can we use that to build our evidence? And then as I go through these examples, it will make sense to do it through 3D printing. That's why most of us are doing it. We can do this through 3D printing, therefore we are doing it through 3D printing. But does the evidence support us to be reimbursed for that? And in many cases, one of the things that I keep arguing is that with 3D printed patient-specific implants, we should be able to deliver the implant to the hospital in a much shorter time. If this time is reduced, then this patient who may have bone cancer or whatever, they are not progressing in their cancer. So let's suppose that a traditional method of making this implant takes 8 weeks. Well, in 8 weeks, people can go from stage 2 to stage 3. If I could deliver this implant in a week, I have saved so much in the healthcare system, and could that be used as an evidence for us? So a couple of examples I will present, and I present these examples for a reason. Remember, I talked about that we do not know everything there is to know about patient-specific implants. I'm not talking about a generic cup that we have taken and made a fin over here and a little attachment over here. We're talking about implants which are difficult to design, difficult to put in, and they get reimbursed, but if we could do it with 3D printing in a much shorter amount of time, are there values to it? So here is an example of a patient who was a teenager, bone cancer. This implant was put in. Soon after the implant was put in, there was a fracture. The procedure does not work very well. So the surgeon had to go back in, revise this, and then in this particular case, because this teenager is still growing, they chose to put in what is called an expandable implant. Could we have done this? Now, if you think about this implant, this is a pretty difficult implant to make. By the time we machine this, clean it, porous coat it, send it back to the hospital, it takes about 8 weeks' time. 3D printing, we think we can do this in less than a week. There's an advantage to that. We talked about, is the contralateral side the right aspect to look and design the implant? Right now, we don't have a choice. That is what is available to us. But is there a way to build, using statistical shape modeling, to determine a better model that could be used to fit in patients, and then design an implant right now, right? So if you look at this surgery, you can imagine that this surgery was done probably in the entire day. Over here, the hospital was not worried about, did you save 5 minutes or 15 minutes in surgery? The hospital is going to be worried about, okay, this is a difficult surgery. If this has to be revised, what would have happened, right? So this is an example of a midshaft tibia. Again, a similar kind of situation. A surgeon goes in, has to replace this. They have taken the information from the other tibia, designed this implant, and we are hoping that it would work right. Same thing can happen in the femur as well. Again, you can see the complexity of these implants that could be 3D printed and in a much reduced amount of time, and with more information that we could get from better scanning or better statistical shape modeling. Here is an example, and I'm cautioning some of you, the next slide will be a little gory, but this is a rib cage. So if you look over here, this is the sternum, this is the plate, and you can see that the patient was missing the ribs over here. Now, in this particular case, in a surgery like this, you can imagine that the surgeon will definitely want to have a bone model and all the guides that they could have, right? But you could also imagine that making this implant took us a long, long time. For this young patient, where half the rib has to be replaced because of cancer or for trauma, whatever the case might have been, that is a very difficult situation. You cannot have patients like this walking around knowing that that much of the rib is missing or non-functional. So over there, and I'll skip, okay. Over there, time is of essence. So if you could 3D print it, and we know that 3D printing has a huge advantage because, and I'll explain that in the next slide, you don't have to go through all the steps that are needed in making these. A lot of people talk about, well, you really don't know how to make 3D printed difficult implants. That's actually not true. That might have been true 2 years back, 1 year back. But now there are companies who are very routinely making triflanges right now. Okay? So we know how to make it, but there are some things that I'll talk about a little bit that we could use in cases like this and reduce time to surgery. So how do we normally do this? And we talked about just implants, but don't forget, a 3D printed patient-specific implant will also need a little bit more than that. It would also need instruments that will have to go with it. Okay, it will probably also need a little bit more in your processing methods to that. So a couple of quick slides talking about that. The normal way workflow, traditional 3D printed conventional 3D printed implants is done. You take the scan of the patient, you make a bone model, send the bone model and a proposed implant to the surgeon. The surgeon then evaluates the implant, most likely has to make changes. They'll come back with changes, will suggest. There's a lot of discussion with design engineers. And then eventually a design is accepted by the surgeon. And most often this design, remember I talked about that there was little knowledge of biomechanics and how do we restore biomechanics. At the end of the day, that's what the surgeon is trying to do. But can we use that and can we build an evidence around that? Okay. And so here is a few slides that talk about that, where there is a lot of attempt in 3D printed or conventional patient-matched implants on how do we match these biomechanics. But if there was a way to do this with 3D printed implants, which the data already exists, and if we can deliver it faster, I think the evidence will fall in place. Here's an example of traditional machining, and of course the instruments that go with it. So at the end of the day, what I'm trying to say over here is that even though we don't have an evidence, because we have not gotten there yet, but we think that if you look at traditional, conventional ways of making patient-specific implant, we take a bar stock. Sometimes, depending on the size of the implant, we have to order a special size bar stock. That special size bar stock comes to us, we start machining it. Before you start machining it, somebody has to sit and program the CNC mills that would work and machine it, right? Once you've done that, then you have to figure out how are you going to put this porous structure on it. By the time this part of it is done, it almost takes us about 6 to 8 weeks, depending on the complexity of the implant. If we could 3D print it, where your model has the porous structure. Your model has everything built into it. Probably the only thing you have to do is to clean and polish a few places. Then you get rid of all that. You are not waiting for your bar stock to come. So there are definite advantages in time. So some of the cases I talked about, some things that we still do not know. Age groups of patients. Your patients could be young and old, right? Is there a way we could think about that, okay, you are dealing with patient populations like this, how and what kind of evidence we will build around it? Okay? Activity level. And of course, this is a little bit of a more challenge because people go through cycles of activity level. In my case, more sedentary, but I don't know about you. Body mass, again, that part I'm increasing over there as well. But the body mass also changes, so the biomechanics changes. So there are a lot of things that we still do not know, but we are now walking into the world of 3D printed patient-specific implants and what kind of evidence we should build so that it becomes easier for our payers to pay for these. One of the things that I have talked to many, many surgeons, and I've asked them, well, would you accept something slightly weaker? And the answer always comes down to no. Why is that? Because nobody wants to take a risk with patients. Yesterday on the table, you were the patient. We look after you. Don't worry. So, but one good thing that has happened in the world of 3D printed industry is that in the minds of surgeons, ASTM 136 is a standard material. Everybody thinks that that is a good titanium material. Whatever the strength is, it works. So in the benefit of 3D industry, that has worked for us because this strength is just about slightly bigger. So that's good. Okay, so what are we, at the end of the day, what are we trying to provide and where are we at the moment, right? So if you think about it, we, at least in our case, Zimmer Biomet, we do not have an implant, patient-specific 3D printed implant. We have implant models, bone models, instruments, which could either be specific instruments that could be used in that particular surgery or patient placement guide. At the end of the day, when we build an evidence, we cannot say we are building an evidence for this guide or we are building an evidence for this instrument. The evidence should be built around the whole thing. And we should expand our value to say, yes, if you did not do this, this surgery will have this problem. At least that's the approach some of us in Zimmer Biomet are taking. And so where are we at the moment? Of course, we have some challenges with the implant part, but I think we know how to make these. There are evidences that, depending on which side you look at it, hospital or manufacturers, we can argue that yes, if you use an implant model and if you use a bone model based on that implant, then the surgery would be reduced in time, or the outcome would be reduced, or the chances of scattering the data will be less. So yes, while we can say that yes, these things are there, does it clinically translate? It's a different question, but there's a lot of papers that talk in favor of that. What is missing is still this part, the making of this part, and therefore the evidence that we have to build on this part. I'm going to quickly go through this, but I talked about this. One of the things that has been holding us back is the finishing and cleaning. And, if you think about, I mentioned that there are companies that know how to make tri-flanges. We can do this part. But post-process in our world is still a big unknown. And it's a risky thing, because how do you remove a powder raw material from a porous structure, because in your orthopedic implants you have porous structure, and how do you clean it? And how do you demonstrate that you have done the same? Those things are difficult questions to answer, and that's what is holding us back, even though I can say that, yeah, we know how to make these. So in my mind, this is still something that is preventing us to start in this direction. Okay? I talked about this. Okay, so based on what I described over here, if you think about it, there's an immediate need. We know that there's an immediate need. One way to look at evidence is, if you had not provided an implant to this patient, what would have been the outcome for this patient? Then the argument is, so that is an evidence of, yes, we should provide this implant to this patient. Well, you're already doing it. So why do you have to do it patient-specific? The one and very good argument that I think that we can propose is we can do it much quicker and faster. If we were to do that, then in my mind, we will be able to say that this patient did not progress into a much more difficult procedure, or the cancer did not go from stage 2 to stage 3, something like that. Okay. So in at least just to finish the story off, when I think what will happen is in the next year, 6 months, 1 year, 2 year, all these industries will figure out how to remove the powder, and then we'll all get into the marketplace with patient-specific implants. And then the question will become, well, what's the reimbursement? So the same problem we have today on guides will happen on implants as well. But hopefully with this thought process of at least how we are thinking, it will help us determine what kind of evidence parameters we should be looking at.